All right, welcome everyone for attending our February's 4th Thursday's Lunch and Learn. We're going to go ahead and get started. Please remember to hold any of your questions until the end. We will accept questions over the phone as well as via chat. Right now, everyone is muted. Please be sure if you're on the phone to also mute your phone as well. So I would now like to introduce our speakers. Dr. Elizabeth Kelly is a faculty member at Houston Community College, Coleman College for Health Sciences, and Amy Deutsch is an advanced practice nurse with Memorial Hermann System Cancer Services. They will be presenting patient navigation in emerging health-related workforce.
Good morning, everyone. This is Liz Kelly, and it's a pleasure to have this opportunity through the Breast Health Collaborative to make this presentation and to share the information we have on this topic of the emerging workforce patient navigator. We have three objectives for today. The first one is to discuss the history of the community health worker, patient navigator, and oncology nurse navigator. The second one is to compare and contrast the development and role preparation for the CHW and patient navigator, and finally to describe the role of the oncology nurse navigator. To meet the first objective, I want to present just a few background facts concerning the worldwide development of the patient navigation role as well as the community health worker. The first documentation for the community health worker was found in the 17th century in Russia, where they were called fielders, and they provided basic medical care to military personnel in the field as well as to marginalized communities. Then in the 19th century, the founder of nursing, Florence Nightingale, took herself and 38 other women to the Crimean War to help with the wounded. She was concerned about how environment affected one's health and health status. And from the information she had gathered before she went to the Crimean War as well as afterwards, we know that she started the practice of nursing, which she regarded as a career to receive an educational background. Moving on into the 20th century, 1940 in China, the community health worker was then called the barefoot doctors, and it was modeled after the Russian fielder model. Then an interesting thing took place during the 1970s by the World Health Organization, and they began to write and be concerned about a need for shifting healthcare tasks. And one of the tasks that they included was the community health worker. And then the first publication from the World Health Organization came out about community health workers in the 1980s. And that was followed in the 1990s by the World Health Organization direct reference to community health workers in one of their declarations. In 1984, the country of Iran began using community health workers to lower infant mortality and family planning. And just recently, Brazil, Indonesia, and Tanzania on the worldwide level have begun to use community health workers in family planning as well as mental health. So we can learn from this worldwide picture that individuals and communities have been reaching out to serve others since the beginning of the 17th century on a wide range of human services during periods of conflict as well as over time, and that the particular role of the community health worker has been recognized on the international level. Now let me go briefly to the role of the community health worker, the patient navigator, and the oncology nurse navigator within the United States. During the Civil War, a lady who wanted to be a nurse by the name of Clara Barton found that she could only nurse within the hospital setting where most nurses were found. So she said instead, I'm going out into the battlefields, which she actually did. She gathered up women and took care of patients as they were actually on the battlefield and in the midst of the battles. She also undertook an interesting effort she and the women with whom she was working, to identify the dead and the injured, and they wrote letters home to family members as they could find that information. So here was not only a clinical type or a care type basis, but also an outreach to families in the community. In the United States, during the 1960s and the Great Society, there was legislation that included community health workers, so designated, for anti-poverty programs, and also during the 1960s, community health workers became a part of the Indian Healthcare Service. Within the United States, the first publication on community health workers as a resource for improving healthcare was offered in 1970 by Richter, and then in 1985, two different authors began to indicate that community health workers were natural helpers, and also how they could help out within the emergency room. In the 1990s, it's interesting that Madeline Leininger, who was a major nursing leader, wrote extensively about the role of cultural diversity and the importance of nurses navigating patients across barriers, healthcare barriers. At the same time, the federal government began to develop the role, and also that was the time period in which the Texas legislature established a community health worker study committee, which then was based on legislation and placed the community health worker within the role in Texas. Also during that period, Dr. Harold Freeman from New York City, who was president of the American Cancer Society, began to hold meetings that focused on access for cancer care for the poor. And he began his patient navigation project in Harlem, and then he also began, during that same time period of the 1990s, his Institute for Patient Navigation. In 2001, the Texas established the Community Health Worker Advisory Board, of which the community health workers were the major participants. And at the national level, President George Bush created a cancer panel to identify barriers to cancer care, and in 2002, nurse navigators began assisting all cancer patients. In 2005, breast centers were initially for nursing the common place where you would find nurse navigation. And then also in 2005, patient navigators were included within funding from the National Cancer Institute in order to help reduce cancer disparities. In 2010, the Department of Labor recognized the community health worker as an official position, meaning that they could be officially employed, and the results of that. And then in 2012, in the Affordable Care Act, both the community health worker and the patient navigator were included in the Affordable Care Act. And in 2007, the National Cancer Oncology Nurse Group was founded, and in 2014, you found all types of oncology nurse navigators working in a whole variety of areas. So what we see from the outline of these activities in the United States, that since the 19th century, there have been efforts in the United States to work with the underserved at both the local and governmental levels, that the role of the patient navigator is a recent addition in the healthcare field, and that nurses and nursing recognize cultural barriers to health issues, especially cancer, and are including new information into nursing activities, which helps the nursing profession grow. What I'd like to do now is to go on to the second objective, which is to compare and contrast the development and role preparation for the community health worker and the patient navigator. From the historical information that we've just briefly reviewed, we've been introduced to some of the events that have brought these two roles, the patient navigator and the community health worker, into being. So the first thing we want to look at is the role definition for the patient navigator as well as for the community health worker. For the role definition for the navigator, as Dr. Freeman has designated, is the navigator acts as a bridge between two worlds, fragmented, poorly coordinated healthcare systems, and complex biopsychosocial needs and care for cancer patients. And out of this definition, he has established 9 principles of patient navigation to address these health disparities. The Center for Medicare and Medicaid also outline patient navigation duties, and they include in that list 6. It's interesting that when you look at patient navigation, you see that there are businesses being established for profit, and they call themselves patient navigation advocacy consultants. And they help individuals and businesses evaluate and enroll in healthcare plans. There are also nonprofit patient navigation foundations being established who handle appeals for claims, denials, negotiations across medication, medical services for chronically and life-threatening illnesses. So not only do we find patient navigation within a clinical setting, we also find it for profit or within for-profit organizations as well as nonprofit. The role of the community health worker has been operationalized under a number of different titles. One is probably the most common one, and the one that's in the Department of Labor definition is the community health worker. But when you go to the literature, you find that they're also referred to as lay health navigators. They are referred to as patient navigators, promotora, and also a doula. The central themes for any of these titles has been to bridge or be a liaison between community and healthcare agencies with an emphasis on initial orientation and then follow-up and referral on the continuum basis. The role definition for the community health worker is also to enhance the community's ability to communicate with agencies or within healthcare systems for prevention as well as follow-up, which is mentioned earlier. Also to appreciate culturally and linguistically appropriate interventions and material, and finally to improve client knowledge about personal and community health issues that relate to improving the health of both the individual and the community. They are also either part of a community or become a trusted member of the community. The role development for the community health worker and the patient navigator are illustrated as follows. For the patient navigator, that role development is taking place at 4 different sites within the United States. University of Colorado, Denver is developing the curriculum and undertaking studies. The Cancer Center at George Washington University in Washington, D.C. is the facilitator for many of the studies as well as undertaking their own. Dr. Freeman has an institute in New York City which offers training. And then the University of Hawaii Public Health Department describes the patient navigator through a wide range of tasks within an oncology setting, and that's interesting the way in which they are approaching it. The role development for the community health worker has been based on core competencies which relate to skills within a clinical setting, an agency setting, or a community setting, or as we have seen here in Houston, a combination of those. The educational preparations vary between settings and between states. The role development is enhanced by practicums or internships, and continuing education is also considered a major part of community health worker role development. The role preparation for each. For the for the patient navigator, to go back to those who are working within the field, the University of Colorado offers an online 6-week preparation, and it has 2 different levels of preparation. The George Washington University Medical School Cancer Center in Washington, D.C. is seeking to clarify the role and develop frameworks for the role. The Freeman Institute in New York City offers 2 days in-person training, where they offer an online self-paced training, and that consists of 10 different modules. The project at the University of Hawaii, they offer 6 care strategies and objectives. They review patient navigation curriculums, and it can range anywhere from 4 hours to 400 hours. And they also identify 5 different tasks across a cancer continuum. For the community health worker role preparation across the United States, it's going to vary between 7 to 10 core competencies and related skills, or the curriculum can also be based upon public health issues and health disparities. As you can see, it's going to be varying widely. Preparation settings are going to be within community colleges, either in an academic setting or a continuing education portion of an academic setting, or through agencies, or there are some private businesses. Certification strategies and status will vary, as well as continuing education will vary. Cost-benefit analysis for the patient navigator, of course, has limited information available. There have been 3 studies in 2009 which have shown that 1 additional studies have been made, but that patient navigators are important to increase the rate of cancer screening. Cost-benefit analysis for the community health worker, of course, which has been around a longer period of time, and therefore you would expect more information. Each of the studies in different areas have been found to be cost-effective in terms of both healthcare cost savings, as well as a measure that they call quality-adjusted life years. And this has been especially important to community health workers working with diabetic patients, decreasing emergency room visits, and children missing school with asthma. Specifically in the area of community health workers and cancer issues, there are 2 studies, one just out recently, that use the term patient navigation in terms of community health workers working with community residents to have them know about the screening, succeed or go through the screening, colorectal cancer screening, and then follow up. And they have found that the participants are much more aware of why they need the screening, and that they do a much better job following up. The March of Dimes and some other projects, such as the Georgia Baby Buggy Project, David Oles' work, particularly, which has related community health workers and nurses, have been found to be very, very effective in terms of prenatal care, pregnancy, postpartum depression, and child development. And then there's a recent publication just out that shows that when community health workers are assigned to people being discharged from hospitals, those patients who had follow-up with community health workers visited their doctor more often, they had less rehospitalization, and they expressed greater satisfaction with the health care that they have been provided. And a final comparison between patient navigators and community health workers is that right now the availability for employment of patient navigators is generally within a clinical, an oncology clinical setting, and that those positions are funded, can be funded through the Affordable Care Act. The employment opportunities for community health workers are increasing because as more community health workers are brought into awareness of employers, they are seeing the role that they can play, they're seeing the cost-benefit analysis. An example of this is that the Breast Health Collaborative has a community health worker employed who is also a breast health navigator. So in conclusion, there is, in comparing the role of the CHW and the patient navigator, the patient navigator is focused on one specific health issue within a clinical setting, whereas the community health worker has a wider range of community health issues, and certainly they practice navigation. They share interest in a long-term relationship, and therefore they have broader opportunities with which to seek employment. And now I'd like to turn the final objective over to Amy Deutsch, and she will be describing the role of the oncology nurse navigator.
Thank you for inviting me to be a part of today's presentation on navigation. I think Dr. Kelly has done a fabulous job at presenting the history of navigation. And so I'll sort of start from the nursing side, not certainly emphasizing what went on in the past, but I have to say that I think the initial oncology nurse navigator, or just nurse navigator in general, probably was Florence Nightingale.
Right.
And she was certainly an advocate for patients, and all navigators are, no matter whether they're patient navigators, community health workers, bedside nurses, whatever they are, we all advocate for our populations. Of course, truly nursing on the state side really began to be formalized for oncology nurse navigation through Dr. Harold Freeman. And Dr. Freeman believes, or indicated when he presented at one of our annual summits here in Houston, he indicated that there can be all types of navigators. The ability to accomplish navigation, though, is sort of leveled, or there are various levels of navigation that each particular entity can achieve. There could be a social work navigator. There could be a nurse navigator. There could be a lay navigator. And as you move up that chain, more patient or survivor issues can be addressed. But I think one of the things that needs to be emphasized is he wanted to turn the late diagnosis of breast cancer, the late stage breast cancer diagnosis, around in his population. Ladies were not being screened properly. They were not getting screened or even getting to screenings. And he wanted to turn late diagnosed breast cancer into earlier stage diagnosed breast cancer. And so that sort of leads me to the nurse navigation role. And basically, oncology nurse navigators have emerged from the field of navigation to respond to the total patient care needs, if you will, across a very complex and highly fragmented healthcare system in our nation. And this is for all types of patients, not just restricted to a single cancer focus. Now, albeit breast cancer was really where nurse navigators first came to fruition. But now, nurses can navigate any number of cancer diagnoses, not just breast. Might be lung, might be head and neck, might be thoracic. Really, any cancer patient can be navigated. Another thing that sort of is playing with the development of nurse navigators is that hospitals and healthcare systems that maintain accredited cancer programs are required to have a navigation component. And that is an accreditation requirement by the American College of Surgeons Commission on Cancer. And healthcare systems, hospitals, entities that ascribe to this type of accreditation are striving for improved outcomes, for better efficiencies in patient care, for increased patient satisfaction. And some of those metrics that are being looked at are length of time from initial suspicion to diagnosis, time to treatment. And what we're endeavoring to do is knock down those times or lessen those times. We also look at things like readmission rates. Many patients get readmitted needlessly, or more often than is actually necessary. They can be navigated properly and then perhaps don't need to be readmitted so frequently. Of course, there's a high level of distress in the cancer patient population, especially at initial diagnosis. And we found that oncology nurse navigators becoming involved with newly diagnosed patients early on, those newly diagnosed patients have a tendency to do much better from a distress standpoint. At the end of 2013, a publication related to a legitimate clinical trial that was conducted by Dr. Wagner and Dr. Ruth McCorkle. Dr. Ruth McCorkle is from the Yale School of Nursing and is a professor of epidemiology at the Yale School of Public Health as well. And, you know, we subjectively know that patients seem to do better by virtue of the comments we hear. Oh, my navigator helped me with this or that. But the problem is that there hasn't been a lot of true clinical trials to address this. And so this is sort of a pivotal study. And I want to share a little bit about it. It was a randomized controlled trial. They had 251 adult patients newly diagnosed with cancer. And they were either assigned to receive care with an oncology nurse navigator for 4 months, starting 2 weeks after diagnosis, or they were assigned to enhanced usual care, which was an educational activity, if you will, and literature. And so basically, of the 251 adult patients, 190 of them, as you might guess, were breast cancer survivors, 30 had lung cancer, and 31 were colorectal cancer survivors. What they found, the differences between the two groups, were that in the oncology nurse navigator group, that the benefits of that interaction with the oncology nurse navigator were found to be in place up to 8 months after diagnosis. And so there's a suggestion from that study that perhaps navigators are helping to improve the confidence of patients that get newly diagnosed with cancer. Maybe to help manage their own illnesses a little more actively. Also, it should be noted that the use of the oncology nurse navigator did not over time increase care costs. And in fact, quality of life, it was indicated that quality of life perhaps was high in this group of patients that participated in the study to begin with. I should mention that the nurse navigators had an average of 18 contacts with the patient weekly per telephone and also in person, some visits, even going to the doctor's office with their clients. And in fact, this is one of the first solid clinical trials that affirms the benefits of oncology nurse navigation. And I personally think navigation in general. To tell you a little bit about role preparation, oncology nurse navigators are typically clinical professionals, registered nurses. Most seem to have at least a bachelor's degree, though not all do. Some at the master's level and some at higher levels as well. They typically are oncology certified nurses or have a certification in an area of expertise for which patients they may be navigating, such as breast health certification. Within the Memorial Hermann healthcare system, we expect our navigators to be seasoned oncology nurses, to have oncology certification or to gain it within a certain number of months, and to be primarily a Bachelor of Science in Nursing at minimum. Also, excuse me, what we know is that because of the experience and the clinical capacity of the RN, they are best able to collaborate with all members of the multidisciplinary team, from community health worker, lay navigator, up to physician, social worker, speech therapist, physical therapist, whatever that might consist of in that multidisciplinary team. The oncology nurse navigators are governed by 5 core competencies, which I will share with you. These were developed by the National Coalition of Oncology Nurse Navigators and released in 2009. The first core competency includes professional, legal, and ethical nursing practice. The second one includes health promotion and health education. The third one is management and leadership. The fourth is advocacy. And the fifth is personal effectiveness and professional development. It's not all about role preparation, but constant education as well, and staying current on what the latest evidence-based practice guidelines are for their population. Oncology nurse navigators are generally embedded in healthcare facilities or in clinics. And so they're not typically out in the community. That is why I personally believe that it is important to develop a collegial relationship with patient navigators, community health workers, lay navigators, whatever term is utilized. And to that effort, we, within our healthcare system, in the oncology cancer service line, have partnered with Houston Community College to offer formal practicums based on the 8 core competencies for community health workers within our healthcare system. And those community health workers get precepted by oncology nurse navigators. Because nurse navigators aren't typically based out in the communities, it's very helpful to forge that bond, because both together can actually deal more comprehensively than any single entity. So it's not about who's better, who's best, but what we can do collaboratively to best meet the needs of survivors, from initial suspicion screening, screening prevention, to diagnosis, therapeutic intervention, and then best supportive care and survivorship ongoing. I think that it's the best of both worlds for the patient together. I will tell you that the oncology nurse navigation within our system started in 2006. We had 1 oncology nurse navigator. We now have 9 oncology nurse navigators. Some focus on breast and some focus on non-breast patients. So there is a wide variety. And navigators are based at all our campuses that have accredited cancer programs. And finally, I'd like to mention that we have seen, in metric standpoint, we have seen improved patient satisfaction. We have seen a decrease in time to treat and time to diagnosis. So we do see some cost benefit here. Of course, we're always looking to decrease out-migration from our healthcare system to other private entities. So that is also a piece that we look for assistance with in navigation. And lastly, I might add that there are 2 professional organizations out there. One is, the first one that was on the, that hit the scene was the National Coalition of Oncology Nurse Navigators. And while that membership is primarily oncology nurses or nursing members, they do have associate members for community health workers, patient navigators, and that you may find online, National Coalition of Oncology Nurse Navigators. And their national meeting is coming up June 12th to the 14th in Atlanta, Georgia. Standard registration is $195. Early registration is $125. The other organization is called the Academy of Oncology Nurse Navigators, Oncology Nurse Plus patient navigators. They've recently changed their names to further embrace patient navigators, community health workers, etc. Now, I will tell you that their annual meeting is coming up September 18th to 21st in Orlando, Florida. Basic registration fee is $450. And that's not including, that's for somebody who's already a member. You will find that membership fees are also very different from one organization to the other, although I will say that the Academy of Oncology Nurse Plus Patient Navigators has a much higher membership than the National Coalition of Oncology Nurse Navigators. Both, though, I think are applicable for anybody interested in navigation. So I hope you've seen the difference between the oncology nurse navigator versus the non-oncology nurse navigator, but how they both can work collaboratively. So when that nurse navigator is a part of that patient discharge back to their home in the community, perhaps that forged relationship between the community health worker, patient navigator, and the oncology nurse navigator will better help that patient with community health worker, patient navigator follow-up once they return home. Thank you.
Okay, so now I'm going to unmute the phone.
All callers are muted. All callers are unmuted.
So if you're on the phone and you have a question, please unmute yourself and ask, or if you would prefer to type in your question, I can read it aloud and we will answer it aloud as well. Wonderful presentation. Thank you so much. Learned a lot. Any questions in the room? Also, we have a few people here in person.
Oh, then everybody's all knowledgeable and we're done. We're ready to go. Sure.
We have patient advocates who have been involved into the whole system of taking care of the patients and being so involved, and some of them are survivors and they kind of have the grips of what's going on, but they are not clinical nurses or whatever, and might be interested in navigation. I'm talking from a personal point of view. I've been always interested in doing that. In fact, I applied for a scholarship with Hermann. But listening to you, it looks like you have to have a clinical background in order to be a patient navigator.
I'm qualifying that by saying to be an oncology nurse navigator. There's a difference.
Okay.
And I will also say that some of our oncology nurse navigators are in fact survivors themselves.
Could
So
we-
they understand both sides. Oh, the question
Yes,
was,
thank you.
the question was asked, just to be a patient navigator in general, do you have to have a clinical background? And my comment was, from the oncology nursing side, you are expected to be a nurse, an oncology nurse in essence. Whereas a patient navigator in general does not necessarily have to be that RN.
But many of our students within the Houston Community College CHW program are themselves survivors. In fact, our first class, which was funded by the Coleman Foundation, the majority of those were breast cancer survivors who wanted to take what you are referencing, which is patient advocacy, and go beyond that and enhance skills. And within Texas, it's for the community health worker, it's 8 core competencies, one of which is advocacy. And by the time they finished their initial education and then their practicum, they were able to find employment and are doing what you're referencing, which is advocating for many women particularly, and finding lots of different ways to advocate for them, be they in a clinical setting, a agency setting, and it's the skills that they learn through that learning process.
I see that there's,
Yeah, I can.
okay, but I want to make one more comment. If you look at the patient, the survivor, not just from a psycho-emotional standpoint, but from a physical well-being standpoint, a social well-being standpoint, a psycho-emotional well-being standpoint, and a spiritual well-being standpoint. If you want to cover all four of those entities properly, the person that can do all four of those entities is a nurse. There are limitations because the social worker may not be able to dialogue about the actual idiosyncrasies, bone suppression, or whatever that patient might be going through that's leading to fatigue or infection or any number of things. The nurse can do that. The social worker, the nurse can address social well-being issues, transportation and things like that, but the social worker may have a greater knowledge base about perhaps some resources, and it's a collaboration, really, truth be told. I think everybody can help address the psycho-emotional piece, for sure. Everybody may be able to address the spiritual piece, depending upon where you're coming from. And so understanding the patient globally, not just from the initial shock of a diagnosis of cancer, but know that there's also physical ailments that can create distress in that population. My pain's not being managed. I'm vomiting my toenails up, whatever that looks like. Okay.
Thank you.
So we have a few more questions. Mary James submitted a question. Could you please elaborate or maybe reword your question, and we'll come back to it because I don't quite understand it. But we have another question. Great presentation. Can you share how navigators follow their patients into survivorship, and if this is being documented as to how it may or may not affect their survivorship?
Yeah, I can address that. We have oncology nurse navigators that facilitate support groups. They may facilitate them collaboratively with a chaplain or with a social worker or with another nurse, might be even with a counselor, a licensed professional counselor. We have oncology nurse navigators that lead yoga classes that are specific for cancer patients. Oncology nurse navigators within our system also collaborate with CanCare, and we offer Back to the Future classes. These are for survivors, and that Back to the Future, pretty much almost everything that we do is free, and it's not just for Memorial Hermann patient populations, if you will. What we offer is open to survivors from really any of the healthcare entities in town. And so part and parcel, it could be that they're leading the support groups. It could be that they're speaking at conferences. It could be that they're now fitting breast cancer survivors, mastectomy patients with prosthesis. Our navigators have taken over that program from the American Cancer Society. And we have 7 closets that we're doing fittings out of. So there's a lot of different ways that we support survivors. And it may be that somebody has achieved a remission and we don't hear from them for a while. And then they fall out of remission and they pick up the phone and they recontact their nurse navigator. And the navigator will pick them back up and follow that population.
So now we have a comment. Missed most of the presentation, but I am concerned because our case managers refuse to communicate with the providers that referred the patient in. Hence, we end up having unnecessary duplication of services or a lab being done before the follow-up lab is due. Any comments or suggestions?
Darlene, this is Amy, I need a little bit of clarification. Are you saying that you have case managers that are like the Lone Ranger and they are not being collaborative with a greater multidisciplinary team? I'm not sure I understand that question exactly.
Okay, so while Darlene's typing, we have another question. Are there any nurse navigator services currently available for home health patients?
I personally am not aware of them. However, That being said, I believe that there is an entity in town that is investigating that option. And I'm not totally at liberty to speak on that yet. Sorry, I can't offer
Oh,
more.
it's
I'm
okay.
not aware that there's one. That doesn't mean there isn't,
Yeah.
but I'm not aware that there's one currently out there.
Okay, we have a few participants typing. Anyone on the phone can ask questions too. Okay, we got a thank you for the presentation. And then we'll wait for more clarification from Darlene.
Let me also comment too, this is Amy again, that community health workers may not have to be cancer focused. Certainly, navigators, whether they're called community health workers or lay navigators or whatever they are, you heard Dr. Kelly mention how many different types of illnesses they're involved with. And maybe you could elaborate on some of that, like what's going on in New York City beyond the cancer domain, or San Francisco, or any number.
Yeah, community health workers are found in a lot of different health arenas, and they, for the most part, start from a community-based issue. For example, the pediatric asthma program that was developed in part of New York City. The hospital was losing a lot of money from emergency room visits, unnecessary emergency room visits from children and their families, because the families couldn't control the children's asthma. The schools were complaining that these sick children were not in school, so they're losing money. So there's two groups that are losing money. The two groups came together and had some community leaders say, we live in these high rises. Will you, the hospital, train us to educate us to know how to work with the patient and the family? And what they discovered was that with proper preparation, these community health workers could then be supervised by someone from the hospital. So when the mother had a child in distress at 2 o'clock in the morning, first call the community health worker. She went through a protocol with the mother, did some visual assessment, and worked with the mother. Then if she thought that the child was of such a nature with the asthma, then she would have the mother call the emergency room, the designated unit, and speak and report to the physician. Then the physician and the mother would make the determination as to whether the child needed to go in or could wait until in the morning. If the child needed to go in, then the community health worker stayed with the family and got the other children off. So there was this multi-level involvement of the community health worker. And yes, it saved the hospital a lot of money, it saved the school system a lot of money, but the most outstanding result was that the family of the child or children were better able to respond and understand how to process the illness of asthma, and they became much better care providers, and the family became less stressed about this illness.
I think also there was a study that was done, in fact, I know there was a study that was done by a doctoral nursing student out in Nebraska through Creighton, I believe it's Creighton University. And that particular nurse looked at the benefit of, in the hypertensive patient population, of a lay navigator, patient navigator with that population, and provided those individuals with some training to deliver the intervention that she was researching. And they found that the population did better on keeping their blood pressure in check with follow-up within the home by those individuals. So that was kind of an interesting.
Right. And the same thing has been found with family planning, early teen pregnancy, child development, getting the young mother on to school. But it's been an ongoing kind of community involvement. and the trust that was built up between the mothers and the community health worker then enabled the young mother particularly to see herself in a different role. And that therefore affected the child development outcomes.
There's another study based, on the community health workers, especially in low-income communities. The community health workers are normally from within the community
Right.
itself, so the families feel more comfortable
Yes.
and more familiar with the people and their trust. So the trust issue is there,
Yes.
and it's, it deals very well with myths and stigma where
Mm-hmm.
the well-developed countries representing them
Right.
would deal better with the community health worker than they
The
would
white
deal-
jacket.
than they would deal with a white jacket, and
Right.
especially in things like HIV and all these infectious diseases, and they found that they are very effective.
Right.
Sure.
And the World Health Organization has identified that, as well as the Clinton Foundation, who are very proactive in terms of working with local personnel to establish how they understand the issue and then work from that understanding, not just say this is a disease and we're going to treat it. This is a community issue.
And when you partner the nurse with the community health
Mhm.
worker,
Yes.
the information, the healthcare information can be transmitted through that community health worker, very capably. Now, I do want to acknowledge that a community health worker cannot take the place of a nurse at that level, but working collaboratively, it is much better for whatever patient population.
I'm going to read Darlene's comment. She expanded a bit more, and then we probably will close questions. So she says, all unlicensed staff and just don't really get the training and or understand the role and responsibility. And they sure don't like hearing it from me, their supervisor, nurse practitioner, clinical services director, like their mother telling them. So I wish the programs that fund our CMs would train them appropriately. So I guess she's referring back to the case managers.
Well, maybe it's, I don't. I guess the only thing that I could say to this is there is a place for proper training of a navigator, and it's not going to be accomplished in 4 hours. It doesn't, if you're talking about patient navigation, you're talking about a human life. 4 hours is not enough to truly care for that human life. So, I mean, Dr. Kelly's presentation said that there were some programs that had 4-hour classes and some programs that had 400. That's a huge disparity. And really, that's a travesty for navigators in general and for their population that they care for.
And also, I think there needs to be a lot more conversation and clarification around what is patient navigation, because professionally, and I'm also a nurse, I've done that with patients in cardiology. So there's a hope that we can get more clarification for this, and always think about the educational preparation, because we do have a problem in this country with low health literacy levels, and if we keep our people involved in healthcare at that same level, then we're creating more problems.
And so our final comment to close the webinar. So it says, this is Amber from the Freeman Institute in New York City. And I'm so happy to hear that folks are talking about the need for and place for lay navigators, as well as community health workers, and that there needs to be collaboration between all. So.
Hey, we did hear that from Dr. Freeman loud and clear.
Yes. So again, thank you so much, Dr. Kelly and Amy, for the very informative presentation. We really appreciate it. I would also like to thank our program committee for organizing the webinars. The committee is chaired by Denise LaRue of Paracel Systems, and the members include Linda Ciballeto with, we have another comment. Okay, pause that. So, I think this is Amber's comment continued. So,
There's unique elements up there.
oh, no, sorry. So this is a new comment. So community health workers working with nurse navigators is a great partnership. Sorry, it keeps jumping. In my opinion, there are so many people who have obstacles or boundaries preventing them from the health services they really need. I'm glad this program is in place and that I am a current student. I hope I can make an impact. And then we have another Susan saying thank you to Amber. And then this is great to hear that community health workers will help patients navigate into the system. So again, our program committee members include Linda C. Vallejo with MD Anderson Cancer Center, and Laura Pena and Lizette Martinez, both with Harris Health System as well. So our next free webinar is Thursday, March 27th on navigating through survivorship. It'll be presented by Kelly P. Hodges and Latanya Neely with Sisters Network, and registration is available on our website at www.bhttx.org. Thank you so much, everyone, for your time, participation, and attendance. Hope everyone has